دكتور شريف عيسى اتفضل يا دكتور شريف. استاذ الدكتور محمد عوض طبعا لو سمحت. متشكر لحضرتك. ويعني مسؤول البلورال ديزيز في الجمعية وفي مصر الاستاذ الدكتور احمد الحلفاوي. اتفضل يا دكتور. دكتور احمد call for the first speaker لو سمحت. دكتور احمد call for the first speaker.
السلام عليكم. نشكر طبعا الدكتور طارق صفوت الدكتور عادل على التنظيم وفي بقيه الفريق كله على التنظيم النهارده، وشرف ليا اكون متواجد النهارده في جلسه البلورال ديزيز اللي معانا. one of the figures in plural diseases صراحه دكتور ريتشارد لايت، هو بروفيسور اوف ميديسن في فاندربيلت يونيفرسيتي في تينيسي. دكتور لايت طبعا هو الاوثر بتاع اللايت كرايتيريا اللي احنا بنستخدمها كل يوم في الديفرنشيشن بين ترانسوديت واكسوديتس. بقالها 45 years يعني برغم كل التشالنجز والديسبيوتس it's still standing. It is the gold standard of diagnosing or differentiation between transudates and exudates. He's the author of Plural Disease textbook. And that's his fourth visit in Egypt. He's almost welcome, always welcome. Dr. Light, please.
Thank you very much. It's really an honor for me to be back in Egypt and be invited by the board of the 16th Regional Annual Assembly meeting of the ESSB. This is my fourth time in Cairo. I love your country. It's just a very special country. And a special thing about it right now is my son is the U.S. Naval Attaché in the embassy. So I got to see him, his wife, and his kids. So that was really nice. What I want to do this morning is talk about the diagnosis and management of pneumonic pleural effusions. Okay, this is a picture that my wife took from Alaska. And I think most of us think that when it's cold, we're more likely to get pneumonia. As Dr. Gouda just talked about pneumococcal disease, I think we're likely to get pneumococcal disease when it's very cold. I realize it never gets this cold in Egypt. Definitions. A pneumonic effusion is any pleural effusion secondary to pneumonia, be it bacterial or viral or lung abscess. An empyema is pus in the pleural space, and pus by definition is thick, viscid fluid which appears purulent. A complicated pneumonic effusion is a pneumonic effusion for which invasive procedures are necessary for its resolution. Significance of pneumonic effusions in the United States. Approximately 1 million patients are hospitalized each year with pneumonia. And as we just heard, about 800,000 have pneumococcal disease. Now 20 to 40% have an accompanying pleural effusion. And if you look at the mortality of patients with pneumonia, it's higher in patients with pleural effusions. The mortality risk is 6.5 times higher if it's bilateral. It's 3.7 times higher if it's unilateral. And I think some of the excess mortality is due to mismanagement of the pleural effusion. Now, I think when you see a patient with pneumonia, you should suspect pneumonic effusion in all cases. I don't think an AP portable film is sufficient. I think it's much better to have a PA and a lateral film. And on the lateral film, look for the outlines of the diaphragm. If the diaphragms cannot be seen, do further evaluation to assess the possibility of a pleural effusion. Chest CT scan is probably the best, but certainly ultrasound is being used more and more. And you can still do a lateral decubitus film, but I think that's rarely done anymore. What are the characteristics of the pleural fluid with a pneumonic effusion? The pleural fluid is an exudate with predominantly polys. The lower the glucose, the worse the problem. The lower the pH, the worse the problem. The higher the LDH, the worse the problem. And if you have a high LDH and a low pH and a low glucose, and your initial gram stain is negative, if you spin the fluid down and gram stain the sediment, your gram stain will be more sensitive. Pneumonic effusion, clinical characteristics. The symptoms can be either acute or chronic. If you have an anaerobic infection, it tends to be more chronic. Weight loss and anemia are common with anaerobic infections. And the clinical picture is the same in patients with pneumonia, whether or not they have a pneumonic effusion. And the clinical picture is also similar with complicated and uncomplicated pneumonic effusions. Now, what's a bacteriology of pneumonic effusions? This is probably the best study of the bacteriology of pneumonic effusions that's ever been done. And it's a MIST-1 trial of streptokinase. But they also were very careful to culture the pleural fluid. They underwent standard culture, and then they did a screen for bacteria by amplification and sequencing of bacterial 165 ribosome RNA genes. They did put the pleural fluid into blood culture bottles. It's much better to put your pleural fluid into blood culture bottles. Your sensitivity of the cultures will increase. Of their patients, 58% had positive cultures, 16% had negative cultures but positive nuclear amplification studies, and 26% had both negative cultures and negative nuclear amplification studies. And what were the etiologies? What bugs caused the pleural effusions? Okay, this shows the etiology of the 335 community-acquired pleural infections. And you can see that strep pneumonia only accounts for 13%. And you want to see the ones that account for the most? It's the strep malaria, which is a semi-anaerobe. Now, if we look at the hospital-acquired pleural infections, again, the pneumococcus is relatively uncommon. We have a lot of staph. We have a lot of Pseudomonas. We have a lot of anaerobes. MRSA is probably the leading cause. So whether or not your pneumonia is community-acquired or hospital-acquired will certainly affect your bacteriology. Now, I think it's important to realize that not all pneumonic effusions are the same, as shown by an older classification that I came up with. And the ACCP came up with this classification to help the practicing physician. It's based on three things. One, the anatomy of the pleural space. Two, the bacteriology of the pleural fluid. And three, the chemical characteristics of the fluid. Boy, that's not supposed to be there. Something went wrong here. Okay. I apologize. I think in general, when we are treating a patient with a pneumonic effusion, the treatment depends on the specialist to a certain extent. Certainly in the United States it does, and I would guess it probably also does in Egypt. If you have a family practice physician, he will observe the patient and do nothing about the pleural fluid. If you have an internist, he will do a thoracentesis in several days if the patient is doing poorly. If you have a pulmonologist, you do an early thoracentesis, put chest tubes in plus TPA and DNAs. You have a radiologist, you put multiple small chest tubes and use fibrinolytics. If you have a young chest surgeon, you do thoracoscopy. If you have an old chest surgeon, you do an open thoracotomy. Now, how do I think you should manage your patient? What are the treatment options? Well, we can observe, we can do a diagnostic thoracentesis, we can do a therapeutic thoracentesis, we can put a chest tube in, we can put a chest tube in with fibrinolytics, we can do thoracoscopy, or we can do thoracotomy. Now, the ACCP developed a classification based on the anatomy, the bacteriology, and the radiology of the pleural fluid. With respect to the anatomy, an A0 pleural effusion was minimal, free-flowing effusion, less than 10 millimeters on the lateral decubitus or ultrasound. A1 was small to moderate free-flowing, more than 10 millimeters, but less than half the hemithorax. A2 was large and free-flowing, more than half the hemithorax, or loculated, or an effusion with a thickened parietal pleura. Pleural fluid bacteriology, BX, the culture and the gram stain were unknown because no thoracentesis was done. B0, negative culture and gram stain. B1, positive culture or gram stain. And B2, pus in the pleural space. Pleural fluid chemistry, CX, the pH was unknown. C0, the pH was above 7.2. C1, the pH is below 7.2. If you use the pH, you must measure it with a blood gas machine. You cannot use a pH meter or a dipstick. And if you don't have a pH available, then you can use a glucose of 60 as the dividing line. The ACCP came up with 4 categories in their treatment of parapneumonic effusions. Category 1 was the minor anatomic with a small effusion that's free-flowing, negative or unknown bacteriology, unknown chemistry. They recommended no drainage. Category 2 was a bigger one, or it still had a negative bacteriology and still had a high pH. And then category 3 was a big effusion or a loculated effusion, or had positive bacteriology or a low pH or a low glucose. And category 4 was pus. And the American College of Chest Physicians said that a therapeutic thoracentesis or chest tube alone are insufficient for most patients with category 3 or 4. And they went on to say that fibrinolytics, thoracoscopy, or thoracotomy are acceptable approaches for managing patients with category 3 or 4. Now, I was on the committee that wrote these recommendations, and I don't like these recommendations. I think we need to individualize our patients. So how do I think you should treat your patients with parapneumonic effusions? Well, this is another picture of wintertime from China, again taken by my wife, and we're still getting pneumonia, it's still cold. Now, why isn't that? So when we have a patient with a pneumonia, we need to treat them with antibiotics. And the last 2 speakers before, I think, gave an excellent presentation on antibiotics and infections in general. But certainly if we have a pneumonia and a pleural effusion, we need to treat them with antibiotics. For community-acquired infections, I treat with a beta-lactam plus either an advanced macrolide or a respiratory fluoroquinolone. I think patients should also be given anaerobic coverage with clindamycin or metronidazole. Patients with healthcare-associated infections should be treated with gram-negative enteric bacteria plus MRSA, killing or treated 4 gram-negative enteric bacteria plus the resistant staph with meropenem or vancomycin. Prognostic factors, I think I've shown this before. The higher you are on the slide, the worse it is. If you get pus out of your pleural space, that's bad. If the gram stain is positive, you have a high bacterial burden. If the glucose is low, that's bad. Positive cultures are bad. A low pH, less than 7 is bad. Loculation is bad. A high pleural fluid, LDH, is bad. Now, in order to find out if you have any of these, you need to do a thoracentesis. So my recommendation for the treatment of parapneumonic effusion is that if the fluid is more than 10 millimeters in thickness on the decubitus, I'll perform a therapeutic thoracentesis, not a diagnostic thoracentesis. I believe if I have a needle in the chest, I just will take out all the fluid, and if it never comes back, everybody's happy. Alternatively, you could put a small chest tube in if the patient's in the hospital. If the fluid is loculated, you should insert a chest tube and consider intrapleural fibrinolytics. If the fibrinolytics are ineffective, do thoracoscopy with the breakdown of adhesions. If thoracoscopy is unsuccessful, do a full thoracotomy with decortication. And I think the definitive procedure should be done within 10 days. I think in the United States, many times we wait weeks before we do the definitive procedure. And all that does is make the patient stay in the hospital a lot longer. Now, if I do my therapeutic thoracentesis and the fluid comes back, what do I do? I will repeat the therapeutic thoracentesis if the smears or cultures are positive, the glucose is low, the pH is low, or the LDH is more than 3 times the upper limit of normal for serum. I will observe if none of the above are present and the patient is doing well. Fluid recurs the second time, I'll put a chest tube in if there's bad prognostic factors on the second thoracentesis. Now, how about fibrinolytics? The largest controlled study of fibrinolytics was the MIST one, and they took 454 patients in the UK, and they randomized them to 250,000 units of streptokinase, or 100 milliliters of saline twice a day for 3 days. Multicenter, double-blind study, and there was no difference in the mortality, the need for additional operative procedure, or the length of hospital stay. And even if they did subset analysis, they could not find a subset that was helped by the streptokinase. This is a slide showing the proportion. I don't have. Yeah, here it is. I'm getting it. This shows the percent surviving without surgery. And you can see placebo is actually better than the streptokinase. And the bottom panel shows the placebo versus the streptokinase, the proportion still in the hospital, and they're identical. There's just no evidence from this. The streptokinase alone works. And the people that did this got very depressed when they got the results of the study. Then they did the MIST-2 study. And this was a multicenter, double-blind, randomized study of 210 patients comparing TPA, DNase 5 milligrams, TPA 10 milligrams plus DNase 5 milligrams, and saline. Each were given twice a day for 3 days. And the primary endpoint was a percent reduction of absolute abnormality on a hemithorax between days number 1 and days number 7. So if you had 50% of your hemithorax occupied by pleural fluid on day 1, and you had 25% occupied on day 7, you got a score of plus 25. And you can see that the TPA plus the DNase was significantly better than all the others. And that the TPA and the placebo were identical. Again, no evidence that the fibrinolytic by itself helps. Now, I would guess you do not have DNase in Egypt. Is that right? Because you don't have any patients with cystic fibrosis. And the reason countries have DNase is because you have the cystic fibrosis. I think the DNase is a big addition to the treatment of complicated perineumonia effusions. And I would encourage you to work with the drug companies to get DNase in Egypt. However, it is somewhat expensive. Now, there are some questions about the combination of TPA and DNase. Can the two compounds be mixed, or do they need to be administered individually? They can be mixed. Their original protocol, they administered individually. Do you need to give all 6 doses? It's expensive. Probably not, but this has not really been studied. Can you give the compounds once a day instead of twice a day? And it seems to be effective once a day. And can you give the compounds for more than 3 days? Yes, if you don't have the desired effects after the first 3 days. Thoracoscopy for perineumonia effusions. If I did not have DNase available, and I was having trouble draining my complicated perineumonia effusion, I would go to thoracoscopy early. And this summarizes thoracoscopy for perineumonic effusions, 4 studies with 232 patients. Definitive procedure in 77%, mortality 3%, median time for chest tube drainage post-procedure 3.3 to 7.1 days, median hospital stay post-surgery 5.3 to 12.3 days. These results look great, but they're uncontrolled, and it's been my observation that my thoracic surgeons don't want to operate on a lot of old people with complicated perineumonic effusions. And then what do you do? And that is really a problem. And I don't have a good answer on what you do with them. Okay, time's up. Let me show one more slide, okay? Thoracotomy for perineumonic effusion. It's a larger operation than thoracoscopy. It's indicated when thoracoscopy fails or when drainage is incomplete and thoracoscopy is unavailable. It's better at decortication than thoracoscopy. Conclusions. I recommend a sequential approach. First, a therapeutic thoracentesis, alternatively a small chest tube for a couple of days. Then tube thoracostomy with fibrinolytics plus DNA ACE if the fluid cannot be removed. Then thoracoscopy with a breakdown of adhesions and possible decortication. Then thoracotomy with decortication. And the definitive procedure should be done within 10 days. And you treat the patient right, and everything gets pretty. And this is a picture from the Butchart Gardens in Canada. Thank you very much for your attention.
Thank you, Professor Light, for this illustrated talk, and it's my pleasure to introduce the next speaker, Professor Ahmed Alafawi, about phenotyping malignant effusion.
It's always a pleasure to be in a session with Dr. Light, and it's a bit challenging to give a talk after his talk and before his talk on malignant pleural effusion, but I will be very quick. I'm sure he will cover most of the points that I will give this talk. I will discuss today phenotyping malignant pleural effusions. What is phenotyping malignant pleural effusions? Actually, malignant pleural effusion is an area with relatively scarce research projects, and some facts and points have been there for a long time. They haven't been changed, like using talc for pleurodesis, which has been there since 1935, and the Light's criteria that's been here for 45 years now. Pleurodesis is a very crude maneuver. It entails destroying or inflaming inducing inflammation to the pleura to occlude the pleural space, but that's the option that we have to manage these patients. And the most recent advance, which is the indwelling pleural catheters, has been there for almost 20 years now. The management differs among centers worldwide, so we don't have clear recommendations because it relies mainly on expertise and resources in different countries, and it's protocol based, not taking into consideration subjects, variables like patients' comorbidities, the rate of accumulation of the fluid, the tumor type and characteristics. It deals with malignant pleural effusion as a single entity. Even the pleurodesis agents that we use, we only know of one dose. We don't alter these doses according to patients' characteristics. And in the area of personalized, individualized, and precision medicine, there is need for tailored approaches to management. That's why we need to categorize or subcategorize these patients, which is the phenotyping. The options of managing pleural effusions, as we'll see with Dr. Light, repeated thoracentesis, they're uncomfortable, risky, and we don't really know which patients to give repeated thoracentesis. That needs to be detailed. Pleurodesis is the ultimate goal that we need to do, but it requires complete lung re-expansion and requires hospitalizations for 5 to 10 days. So people with very limited life expectancy should not stay a good part of their remaining life in hospital. So this is reserved for patients with life expectancy of more than 3 months. but predicting mortality in these patients is problematic. Indwelling pleural catheter, it's becoming more and more popular worldwide. There is a rate of spontaneous pleurodesis, and you can treat the patients at home, and it can be combined with pleurodesis for a better outcome. The surgical options through VATS or pleurectomy are reserved for those patients with very good prognosis, and also we don't know which patients we term that have good prognosis. And so in categorizing these patients, we need to look at different points: the prognosis, the performance status, the tumor burden in the pleural space, the pleural tumor type. I'll give a hint about the Lent score, and we need to see which patients will benefit from pleurodesis and the rate of recurrence of that effusion. The prognosis, the survival of these patients usually ranges from 3 to 12 months. Ranges from 3 to 12 months. Patients with better expectant survival require a definitive treatment, mainly pleurodesis or the indwelling pleural catheter. The indwelling pleural catheters may be more costly, although initially it's less costly because we don't admit the patients, but in patients who survive for a long time, the drainage kits and the nursing care makes it more expensive. And I had the pleasure to publish a paper with Dr. Light about how to reduce the cost of these of draining these catheters with a reusable device. We also need to look at the performance status of these patients. That can be assessed by the Karnofsky Functional Performance Scale or the Eastern Cooperative Oncology Group, the ECOG. Well, the better the Karnofsky scale, the longer the median survival, and patients whose Karnofsky scale is below 30, they have a very short median survival of 34 days. So the low KFS predicts early mortality and failure of pleurodesis. And that's the Karnofsky scale and the ECOG performance status, which are usually almost very similar, but this one is easier. And how do we assess the burden of the tumor inside the pleura? That can be assessed by direct vision if we do a thoracoscopy. We can assess the tumor volume and activity by PET CT and also by biochemical tests. So the more tumor there is in the pleural space, the more metabolites, the lower pH and higher LDH. There's also a neutrophil to lymphocyte ratio where a higher neutrophil to lymphocyte ratio is related to poor prognosis. We can measure the cervivin molecule that predicts poor prognosis. A bloody pleural effusion is definitely worse than an exclusive effusion, and if there are extensive adhesions inside the pleural space during thoracoscopy. Some types of tumors have worse prognosis. So lung, GIT, and ovary, they have a mean survival of 4 months. But whereas chemosensitive tumors like breast and lymphoma have better prognosis. And now we have targeted therapies. We look at EGFR positive lung cancers as types of cancers with better prognosis because we have now more advanced treatments targeting these types of cells. In Taiwan, in a study, they found that in lung adenocarcinoma, they had better prognosis if the effusion appeared late after the diagnosis, if the EGFR was positive, if age was less than 65, and the tumor was confined to one hemithorax. The mean survival in EGFR positive was 19 months, whereas EGFR negative was 7 months. Patients with breast cancer have better prognosis if the effusion was discovered later in the disease course, if the tumor cell was hormone receptor positive, and if they had deficiency here in EGFR receptors. malignant mesothelioma, bad disease, but some patients do better. Patients with epithelioid subtype, they have good Karnofsky scale, earlier stage with no chest pain, no invasion of surrounding structures, female patients, and the absence of systemic inflammation. Lung cancer and mesothelioma tend to have poor outcome in pleurodesis regardless of the chemical agent used or methods of administration of that chemical agent. And there is a score that's been developed to give an idea about the survival of patients presenting with the first malignant pleural effusion, which is the LENT score. LENT stands for lactate dehydrogenase, Eastern Cooperative Oncology Group Performance Score, neutrophil to lymphocyte ratio, and the tumor type that stratified patients into low risk, medium risk, and high risk. So patients with low risk had longer survival of 319 days, medium risk of, they had medium survival of 130, and high risk 44 days only. Also in dealing with patients with malignant effusions, we need to know if those patients will benefit from intervention from drainage of the fluid, because dyspnea can be multifactorial. There are other causes that can cause dyspnea other than the effusion, like atelectasis, embolism, lymphangitis. And so 1/3 of patients may not have symptom relief after drainage. And for sure, radiological appearance is not a reliable guide to the degree of improvement after drainage. Some people have large effusions, they don't have considerable dyspnea. Some people have very little effusion and they feel relatively dyspneic. And there is an ongoing study, the PLEASE study, pleural effusion and symptom evaluation, that tries to see or determine which patients will benefit from drainage of the effusion, looking at muscle power and performance status. It's not there yet. Also, will talc pleurodesis be beneficial for these patients? Talc is known to be a good sclerosant agent, 60 to 75% of success rate in large studies. But we need to know if there is a certain subtype of patients or type of malignancies who will benefit from talc more than others. Will it be beneficial in that type of tumor other than the other? And we know that failure of pleurodesis may be related to lower pH, non-expandable lung, which is actually a contraindication to intervention and performing a pleurodesis, but incomplete re-expansion of the lung can cause failure of pleurodesis. And a patient who has a high daily drainage of more than 200 milliliters will have a poorer outcome at pleurodesis. There are a few methods that we can predict non-expandable lung and failure of pleurodesis without doing thoracentesis. But we can perform manometry. It's not the standard diagnosis. It's not the standard methods to assess these patients, but some centers do perform manometry before attempting pleurodesis in all patients. We need to work on that here in Egypt. A crucial point in malignant pleural effusion, will the effusion recur or not, or how often will it recur? That will determine our intent of treatment, how aggressive we should be. Some studies showed that the larger volume of pleural effusion, that is when it's removed at the first thoracentesis, and the improvement in the symptom that the patient gets, this will indicate that the effusion will recur. It was found that these patients have a faster recurrence within the 30 days of the procedure. And mind you that 390 patients with mesothelioma, more than 90 had effusions, and only 42% of these patients required intervention. So not all malignant pleural effusions need to be attacked. A low pH, an effusion more than 50% of the hemithorax, and an increasing age grants use of definitive therapy because this predicts the effusion will recur. And so definitive therapy with either pleurodesis or indwelling pleural catheter. And to conclude, the ideal therapy of malignant pleural effusion is to prevent formation from the start by finding ways to treat the primary tumor. But individualized therapy for malignant pleural effusion, there still requires a deeper look and insight in these patients. There is a need to generate an algorithm for management of malignant pleural effusion encompassing the different types and phenotypes of malignant pleural effusion patients. It's mandatory to continue to collect study data that will facilitate phenotyping these patients in the future. Thank you very much.
Professor Ahmed Halafawi, I do thank you very much for your excellent presentation and perfect conclusion. Now I am delighted to reintroduce Professor Richard Light, and this presentation, the last presentation for this session, about the diagnosis and the management of malignant pleural effusion. Professor Light.
Okay, thank you. Good morning again. It's good to be back to give the second talk this morning. I'm afraid I'm going to repeat a lot of what Ahmed Halafawi said, but we work together and we think the same. Now, do you know what this is? This is a crab from the Galapagos Islands. And why do I show a crab? Well, when I was an intern and a resident, if we saw a patient and we thought they had a cancer, we would say they have a crab. So let's talk about malignant pleural effusions. The pleural effusion secondary malignancy is the most common cause of subacute or chronic exudative effusion in the geriatric patient. And the pleural effusion indicates systemic dissemination. Surgery cannot cure the patient of the effusion and the malignancy. Overall, it's a bad prognosis. Median survival is about 90 days overall. I think you should treat the effusion only if the patient is dyspneic and only if the patient's dyspnea is relieved with a therapeutic thoracentesis. And as Dr. Halafawi said, a third of the patients don't get any relief after a thoracentesis. There's no use putting an indwelling catheter or pleurodesis in those patients. The patient is not dyspneic, no treatment for the pleural fluid is recommended. Causes of 200,000 cases of malignant effusion in the United States. Lung carcinoma is number 1, breast carcinoma is number 2, lymphoma and leukemia is number 3. The three of those, I only got 3 minutes left. And the combination of lung cancer, breast cancer, lymphoma, and leukemia account for about 75% of all cases of malignant pleural effusions. Now, if you have a patient with a pleural effusion, what is the likelihood that patient has a malignant pleural effusion? And this is a study from Spain a few years ago, and they studied 93 patients. Well, I'm going to get it there in a minute. Boy, that's sensitive. Studied 93 patients. Okay, there. Studied 93 patients. And they found 4 characteristics that predicted whether or not the patient had a malignant pleural effusion. They saw if the patient was febrile or not. They saw if the patient was symptomatic for more than 4 weeks. They assessed whether the pleural fluid was blood-tinged or bloody. and whether the CT scan was suggestive of malignancy with pleural nodules, lung masses, or mediastinal masses. All these patients had negative cytology, and they were going to thoracoscopy, and they found that of the 28 patients that met all criteria, all of them had malignancy. And of the 21 with 1 or 0 criteria, none of them had malignancy. So I think if you think of these 4 things, when you see a patient with a pleural effusion, it will give you a good idea whether or not the patient has a malignant pleural effusion. Pleural fluid cytology. It's a very useful test. The first specimen is positive in 60%. If 3 specimens are submitted, it may be positive in up to 80%. At the present time, if my first cytology is negative, and I think the patient has a good likelihood of having a malignant pleural effusion, I will go to thoracoscopy, my next step. I will not do a second thoracentesis and a third thoracentesis. The pleural fluid cytology is very effective with adenocarcinoma, but it's less effective with lymphoma, squamous cell carcinoma, mesothelioma, or Hodgkin's disease. Tumor markers for diagnosing malignant pleural effusions. There are many tumor markers that have been evaluated, including carbohydrate antigens CA15-3, CA19.9, CA549, CA72.4, cytokeratin fragments, cancer antigens, Cialis stage-specific antigen, neurospecific enolase, squamous cell carcinoma antigen, HER-2/neu, and telomerases. As far as I'm concerned, the main problem with tumor markers is that if a high enough level is set so that there are no false positive, then the tests are very insensitive. And I basically do not use tumor markers to make the diagnosis of malignant pleural effusions. This was a study from Purcell a few years ago, and they measured pleural fluid levels of CEA, CA125, CA15-3, and cytokeratin 19 fragments in 416 patients, including 166 with definite malignant effusions, 77 with probable malignant effusions, and 173 with benign effusions. They established cutoff levels such that all 173 benign effusions were below the cutoff level. But their tumor markers identified only 54% of the malignant pleural effusions. And they suggested you could use the tumor markers as a screen for thoracoscopy. And if your tumor marker is high, then do thoracoscopy. I just think it's easier to see if the patient is febrile, has had symptoms for several weeks, has a bloody pleural effusion, what the CT scan shows. So I do not use tumor markers. Thoracoscopy for the diagnosis of pleural disease. It's very efficient, more than 90%, at establishing the diagnosis of malignancy, including mesothelioma. It's also very good at establishing the diagnosis of tuberculosis. I think it's important to emphasize that rarely does thoracoscopy establish the diagnosis of other benign causes of pleural effusion. You rule in or out TB and cancer, and that's all the thoracoscopy does. I think if the patient has a recurrent pleural effusion and you do thoracoscopy, you should do a procedure at the time of thoracoscopy to create a pleurodesis, whether or not the patient has a cancer, because you just as well take care of the pleural effusion so it won't come back. And I like to use pleural abrasion and insert a tetracycline derivative or 2% silver nitrate. Now, when we have a patient with a malignant pleural effusion, I think we need to treat them with care. And this is one of my wife's favorite pictures, of 2 iguanas. I iguana you. I think we need to iguana the patients and treat them and do what we can to give them the most high quality days the rest of their life. My philosophy of treatment. I realize the life expectancy of the patient is limited. I realize that surgery cannot cure the patient because a pleural effusion indicates that the malignancy is disseminated. The main symptom from the pleural effusion is dyspnea, and the goal is to alleviate the dyspnea via methods that require the shortest or no hospitalization and cause the patient the least distress. As far as I'm concerned, the two primary treatment options are the implantation of an indwelling catheter or injection of an inflammation-producing agent to produce a pleurodesis. There's the prognosis of patients with malignant pleural effusions. As you can see, it varies. Lung is horrible. Breast is pretty good. Lymphoma is in the middle. And if you have a malignant pleural effusion, you live longer with have a mesothelioma than any other malignant pleural effusions. A low pH, a high LDH, a low pleural fluid protein, and large effusion associated with a poor prognosis. The indwelling pleural catheter. The Pleurex, there's also one called the Rocket, are 16.5 French silicon rubber catheters, 66 centimeters long. There's a one-way valve on the end of the Pleurex that allows drainage, and it allows intermittent drainage via vacuum bottles every other day. This is the picture of the catheter, and you can see the holes in it. They're up in the pleural space. And then this part down here, boy, I can't get that to go over there. Anyway, where the little knob is, it hangs over the upper abdomen. And the patient just drains the pleural fluid every day. In some institutions, they only drain it when the patient gets short of breath. And I don't know which one is best. These are the drainage bottles. They're suction bottles. And as Dr. Afawe mentioned, these are relatively expensive. And they're hard to get in Egypt. And I know you don't use a lot of indwelling catheters in Egypt. Insertion of a tunnel indwelling catheter is usually inserted in a procedure room, usually an endoscopy suite. It's done under local anesthesia. It can be done usually as an outpatient. It can be done with ultrasound or fluoroscopic guidance. I think it's best if you use the guidance. The Seldinger technique is used to insert the catheter into the pleural space. The catheter is tunneled under the skin to a counter incision 5 to 8 centimeters away. And the insertion can be done by the pulmonologist, the interventional radiologist, or the surgeon. At Vanderbilt, my university, the insertion is done by the pulmonary fellows for the most part. First large series. Retrospective analysis of 250 tunnel pleural catheter insertions in 223 patients at a single center, Calgary, Canada. 4.4% failed insertion. And they reported that symptom control, dyspnea control, was complete in 39%, partial in another 50%, and no further procedure was necessary in 90.1% of the patients with successful insertions. And they concluded that the tunnel pleural catheter should be the first line treatment in malignant pleural effusions. Second large series, they inserted 295 catheters in 263 patients at Rush Medical Center in Chicago in the United States. Unsuccessful in 10. 58.6% of the catheters could be removed after a mean of 29.4 days because of fluid coming out. And nobody knows why the fluid ceases to be formed in some of these patients. And of this 173 patients that had the catheters removed, only 5, or 2.9%, had reaccumulation of the fluid that produced dyspnea and needed treatment. I want you to remember that 2.9% when I show you the slide on talc pleurodesis in a little bit. The catheters were more likely to be removed in patients with breast or GYN primary tumors, absence of chest wall irradiation, and complete re-expansion of the lung. Pleurodesis with the indwelling pleural catheter. Spontaneous pleurodesis occurs in approximately 50% of patients at a median of 25 days post-catheter insertion. Presently, studies are underway in which silver nitrate is embedded into the Pleurex catheter. And the preliminary study suggests that most of the patients can have the catheters removed within 10 days because the silver nitrate produces the pleurodesis. The biggest advantage, as far as I'm concerned, to the indwelling pleural catheter is that the pleural effusion can be managed entirely as an outpatient. Incidence of spontaneous pleurodesis with the indwelling catheter. These are the different series. Tremblay number 2 towards the bottom, note he had 70%. This was 109 patients where the lung completely re-expanded after the catheter was put in. And if the lung completely expands, you will get the spontaneous pleurodesis in the majority of patients. Review indwelling catheter papers, 2010. There was a review of 19 studies with 1,370 patients who received indwelling catheters. 95.6% had symptomatic improvement. 45.6% had spontaneous pleurodesis. Complications, empyema in 3%. And if a patient with an indwelling catheter gets an empyema, you can leave the catheter in to drain the fluid and treat the patient with antibiotics. They get cellulitis at the insertion of the catheter in a small percent. And then some of the patients, the catheter gets obstructed, and if you put the TPA in, you can relieve the obstruction and leave the catheter in for a lot longer. Now, drainage bottles, as I mentioned, are expensive. This is an inexpensive alternative. It's a surge event that the surgeons use to suck juice out of wounds. And Dr. Hafawe wrote a paper a few years ago where he studied 55 patients where you use this plastic accordion-like structure rather than the suction bottles to drain the pleural fluid. He would drain the pleural fluid twice a day, and then he would sterilize the surge event and the tip of the catheter, and he had no problems with infections. When there was less than 500 cc's output per day, he kept the surge event attached continuously as the device was attached to their waist. And he reported that pleurodesis was achieved in 86.3% of the patients at a mean of 19 days post-insertion. This is the best that anybody's ever reported. And I would encourage you people in Egypt to treat your malignant pleural effusions with the indwelling catheter and use a surge event if it's too hard to get the drainage bottles or if they're too expensive. And there were no device-related complications. Pleurodesis occurs when the covering of the lung, the visceral pleura, and the covering of the inside of the chest wall, the parietal pleura, fuse. The two pleural surfaces are fused, then fluid can't accumulate. Pleurodesis is usually produced by injecting an inflammation-producing agent into the pleural space. The resulting inflammatory reaction leads to pleural fibrosis such that the visceral and the parietal pleura fuse. Agents, the ideal agent for pleurodesis should be widely available, should be inexpensive, should not require hospitalization, should not require chest tube, should have no systemic effects, and should not cause the patient any distress. Unfortunately, I don't know what the ideal agent for a pleurodesis is. Agents for pleurodesis, most commonly used agent is talc. Tetracycline derivatives are also used. When I was a resident, we used nitrogen mustard as an antineoplastic agent. It's still the best in animals, but nobody uses it. Silver nitrate and iodopovidone are both inexpensive, widely available, and I think they are underutilized, and I think they're less dangerous than talc. Pleurodesis with talc, the most popular agent for producing pleurodesis at the present time. It's perceived to be effective, and I emphasize perceived, and the cost is minimal. Talc preparation are quite inhomogeneous, and to me the big problem is that intrapleural talc can lead to the ARDS, acute respiratory distress syndrome, which is fatal in 1 or 2%. If you do autopsies on the people that die, talc is disseminated throughout the body, and the evidence suggests that small talc particles size is responsible for the ARDS. There's no such problems with bleomycin or tetracycline. The biggest study ever on talc, CALGB study, took 486 patients and randomized them to receive talc slurry, where they put the talc in through the chest tube, or talc insufflation, where they aerosolize the talc at thoracoscopy. Their results were not nearly as good as results have been reported in smaller series. Only 60% were alive at 30 days without a recurrence. Those alive at 30 days, 18% already had a recurrence, and 11, or 2.5% of the patients died of ARDS. To me, this is not satisfactory. This shows the time to recurrence of the pleural effusion. And I want you to come over to 50 days here. I'm going to get it in a minute. And you can see there's already a 35% recurrence. And if you come out to 150 days, there's more than a 50% recurrence. And you remember with the indwelling catheter, there's only 5 out of 173 that had a recurrence. So this makes me think that talc is not as good as some Europeans think it is. How about the indwelling catheter compared with talc pleurodesis? Clinical course of 34 patients with the indwelling catheter was compared with that of 31 patients with talc pleurodesis in Australia. They reported that there were 18 days median hospital days in the talc pleurodesis group, and there were only 6.5 days median hospital days in the indwelling catheter group. 10 days related to the effusion in the talc pleurodesis group, 3 days related to the effusion in the indwelling catheter group. I think this is strong evidence that the indwelling catheter is superior to the talc pleurodesis. There's a recent article that will be published in JAMA in the next couple months that shows the same type of effects with the indwelling catheter having less hospital days than the talc pleurodesis. Pleurodesis tetracycline derivatives, agents most commonly used in the 1980s, and the intrapleural administration of tetracycline derivative apparently produces a severe chemical burn of the pleura. Subsequently, get an exudative pleural effusion and pleurodesis. It's extremely painful. At times, it produces the Tachy-Lordy syndrome, and you know what the Tachy-Lordy syndrome is, right? I became familiar with this about 30 years ago when I had a little old lady that I put 1,500 milligrams of tetracycline in her pleural space, and about 6 microseconds after it hit her pleural space, she went, "Oh, Lordy, Lordy, oh, Lordy, oh, Lordy." She was hurting so much. And I mentioned the Tachy-Lordy syndrome to tell you that if you ever use a tetracycline derivative, use conscious sedation. Make the patient nice and sleepy before you inject anything in. You may also use the oral forms of the tetracycline derivatives if you put them through a filter. My pleurodesis procedure, I put a chest tube dissection. I inject as soon as the lung is totally expanded. I use conscious sedation.
Microphone, please, Professor.
I'm sorry. I use conscious sedation. The agent I use most frequently is doxycycline, 500 milligrams and 50 milliliters of saline. Alternatively, I'll use 20 milliliters of 0.5% silver nitrate or 100 milliliters of 2% iodopovidone. I flush with saline. I clamp the tube for a couple hours. I put the chest tube back to suction. Remove the tube when the drainage is less than 100 milliliters for 24 hours. There's no scientific proof that any of these things are right, but this is how I do it. And lastly, I think some of our patients with malignant pleural effusions are dyspneic regardless of what we do. And I think it's important to make them feel better. I'm on my last slide.
Yeah. يا ابني.
Sorry. So there's dyspneic. Either opiates or oxygen will alleviate the dyspnea. The advantage of the opiates is that they will also relieve the pain. The disadvantage of the opiates is that they will produce constipation and sometimes mental clouding. The disadvantage of oxygen is that it is expensive and non-portable. I think opiates are underutilized. And I treat my patients with dyspnea with opiates just like I treat my patients with pain with opiates. And it's my experience that the patients with dyspnea don't accelerate their dose of opiates, but it really makes their life better. So I recommend titrating opiates for dyspnea just as it's done for pain. So in summary, diagnosed with cytology of the pleural fluid, indwelling pleural catheter or pleurodesis if the patient is dyspnea and the dyspnea is relieved with thoracentesis. Pleurex catheter is an excellent option for ambulatory patients. It eliminates the need for hospitalization. It decreases total hospital days. Tetracycline derivative rather than talc, because talc causes ARDS, and opiates are good for dyspnea. And this is a picture from Bali, and I apologize because I went to the camel market in Egypt earlier this week, and I've never seen such chaos in my life, with 2,000 camels running around and the people chasing them, the people beating on the camel. It was fantastic. Thank you very much for your attention.
Thank you so much, Professor Light, for everything, for your enthusiasm, and for sharing a very long and valuable experience. Professor Light will leave tomorrow morning, inshallah, so allow me, on the behalf of the ESSB and all my colleagues here, to give you just the trophy of the ESSB as a gift and a valuable reminder for the society.
Thank you very much. It's been my pleasure to be here. You've been a great audience. That's really impressive. Thank you.
Thank you. We'll help you.
Okay. Okay.
And the next session is a very important session, interactive case presentation. I know, very interesting cases with very interesting discussion, but I beg you to stick to the time. For the first case, let me call the distinguished chairperson and moderators, the panelists, Professor Ramadan Nafi', Professor Gamal Al-Khouli, Professor Usama Fahim, and the moderator is Professor Ahmed Al-Ghazali.